Hello everyone, this is Danny Bobrow, President of AIM Dental Marketing, welcoming you to this installment of the Practice Perfection Web-Based Education Series. Before we get to today's event and our very special presenter, we want to share that the webcast will be 90 minutes in length, and while attendees are in listen-only mode, we do invite you, our dear viewers and listeners, at any time to submit your questions or comments using the question button on your screen. We will allow sufficient time following the presentation to get your questions answered. If, however, we should be unable to answer all your questions during the webcast, the question and answer period, we'll see that it is answered shortly thereafter, as our special presenter today has graciously offered to do that. Today's presentation is entitled Stop the Bleeding: Predictably and Consistently Control the Cause of Periodontal Disease, Breath Odor, and Other Oral Systemic Health Links, and is delivered by Dr. Jim Hyland. Dr. Hyland is a practicing dentist and president of OraVital, the first company to provide an antibiotic rinse and spit system to kill the pathogenic biofilm causing oral infections. He has presided over 2 local dental societies, is on the staff of the University of Toronto Dental School and 2 community colleges, and has published his findings in numerous prestigious clinical periodicals. Dr. Hyland presents the process for transforming the hygiene experience to tackle pathogenic biofilms that are the cause, rather than a symptom of, the infection. In-office biofilm control, consisting of microbiological testing and antibiotic rinses, coupled with the unique home care technique, are the 1-2 punch Dr. Hyland delivers in effective hygiene care. Attendance at this presentation entitles you to receive 1.5 hours of continuing education credit. Shortly following the webcast, you will be emailed a brief survey with instructions on how to receive your CE. Participants are cautioned about the dangers of incorporating techniques and procedures into their practices if the course has not provided them with adequate clinical experience to allow them to perform it competently. And with that, it is now my sincere pleasure to welcome Dr. Jim Hyland. Hello, Jim.
Hello, Danny, and thank you very much for this opportunity to talk to your group, and thank the attendees for taking the time to listen to a presentation that I hope will transform the way they look at treating periodontal disease, techniques they can use to incorporate into their practice, and ways to present and discuss things with their patients that will make the patients, in my experience, want to get healthy and to overcome the insurance barriers and every time I come in it bleeds and you're causing the bleeding and the issues we deal with, time constraints. We want to make the problem something that the patients want to cure, and we will help you do that. About 75% of your patients have periodontal disease in spite of our care. I hope to challenge your assumptions on how you diagnose and treat periodontal disease, breath odor, and control the oral systemic link. As Danny indicated, we want to look at treating the cause versus the symptoms, and that means treating it as a biofilm disease and not as a calculus disease. We want to set goals for the people that we're taking care of and who depend on us. That would be no bleeding for every patient we see. We want to look at objective measurements that help us to determine where the patient is and what progress has been made with our therapies and their care, and not it looks okay, it seems fine, I like the way things are. We have to talk about spirochetes and the type of diseases they cause. We know they're associated with Lyme disease, syphilis, periodontal disease, and even Alzheimer's. And our patients need to know this. And we have to develop a zero tolerance for excess bacteria like this. Just read a Yahoo article today, and it talks about P. gingivalis and T. denticola, and that if you find that your dentist tells you you have these bacteria, it's really bad for your health. So our patients know about this, and they want this information. We have to give them some different instructions on how to care for themselves at home, because the brush and floss mantra is simply not working, and I'll explain what I mean about that in a few minutes. Antibiotics are rarely used for periodontal disease, especially gingivitis and mild to moderate perio, and part of the reason is we don't want to give systemic doses, and that's true. We'll offer an option of the patient rinsing and spitting out the antibiotics without systemic effects, with a very large concentration in the mouth that will penetrate even the most resistant biofilms and bring bleeding shrink pockets, and help control breath odor. We want to reevaluate and have the patients back for reevaluations to make sure the bleeding has stopped, that the pockets have shrunk, and that they are healthy. And we want to involve our patients in the care in an easy way to integrate into your practice predictably and tackling the cause of the problem. So let's take a look at what I'm referring to. I want you to have an open mind like a parachute. We often respond with, that won't work in my practice. My patients won't accept that. And yet other people do the same and they get good success. Want to give insight on how we can eliminate the oral systemic link. If we can control, in particular, spirochetes and P. gingivalis, the gram-negative anaerobes that cause and initiate periodontal disease, we then don't have the oral systemic risk factors. It's a chicken and egg thing, but if you pull out the sliver, you don't have the problem. Once you have the sliver in, you have host-resistant factors that come into play, and we do have to deal with those. But our goal tonight is to talk about decreasing this pathogenic biofilm load. We want to be open to considering new knowledge and techniques, as I mentioned, and not defend the familiar. Our patients deserve this. They want it. They want non-surgical care, and if possible, no systemic antibiotics. The Orovital system will give you the predictable approaches to getting your patients healthy quickly, and quickly is the word. When you take an antibiotic for a bladder infection, lung infection, you expect it to work within a week. And so if we deliver the proper antibiotic in the proper dose where the infection is, we should be able to control the biofilm that causes the disease and should see them healing, and should see them healing quickly. I'll answer any questions that you email to me, and as Danny has mentioned, you will all receive a copy of this webinar, so you don't have to try and write down what's on the screen. So what are the steps then to controlling periodontal disease and breath odor in literally as 2 weeks? We spent our lives saying, I'm going to clean your teeth. And if cleaning teeth twice a year was going to treat periodontal disease and control it or cure it, none of our patients that are seeing us twice a year would have periodontal disease. So our problem is that what we need to treat is the biofilm infection that's there. And yes, we have to do calculus removal. And yes, the teeth have to be cleaned. But if the teeth are clean and the biofilm remains, then the problem still exists. So we have to talk about killing these bacteria, and we have to talk about, with the patient, about connecting these diseases to the oral systemic link. We have to make it personal. They have to know what's in it for me. If they don't know that, they don't make changes in the way that they do things. We have to diagnose the conditions, and we have to demonstrate the extent of the infection visually and emotionally. And I'll show you about a 4-second test to do that. That will transform how the patients look at whether or not they have gum disease. But it has to be done before you scale. If you scale and there's bleeding, you get blamed. If you can show the bleeding before they're scaling, the patient knows they have the disease. We have to link this to the spreading of this infection to their loved ones through kissing, and we have to link it as well to the medical, dental, even their family history as well. So we're recommending that you consider biofilm testing, and it's similar in concept to an oral DNA. It is less expensive and easier to do. We're recommending you consider antibiotic rinses as an adjunct to the therapies that you provide if you find that there's a reason for it in terms of the degree of bleeding or the infection that shows on biofilm testing, and that you always have patients back for reevaluation appointments. If you have a problem where there's blood in your urine, your doctor's going to make sure there's a follow-up to see that the therapy has worked out right. We in dentistry need to do the same for our patients as well. We want to talk about working hard and working smarter. And most of us keep doing the same thing faster, and we don't pay a lot of attention to what's happening. And in dentistry, this is Orovital over here, and we're going to offer you some round wheels. Consider changing the square wheels and trying to do things easier and predictably. Paradigms. These are the ways we do things because we've always done them. The assumptions that we make, it keeps us where we are. And most of the time we say, why should we change? There's a good reason to change. And if we look at the analogy of how stomach ulcers were treated originally, when I was in school in '76, when I graduated, they were to do with a Class A personality, somebody who had too much acid production and had to drink a lot of creams and things like that to coat the stomach. And if they'd only settle down and be nice people and not be so uptight, they wouldn't have the problem they had. And then a general physician in Australia decided it was a biofilm disease. He gave his patients antibiotics, and he cured 2 of them. The specialist didn't agree with him, so he swallowed the bacteria himself. He gave it to himself twice and cured himself twice, and it only took 15 years to become the standard of practice in medicine. And so the approach that I'm mentioning to you today is similar to this. Consider using an antibiotic mouthwash to kill the bacteria if we consider them a serious enough problem so that we can get the patients to a level where it's easier for them to keep themselves healthy. Sorry, I'm pushing the wrong way. So what has changed since we graduated in operative and periodontal care? When I graduated, we didn't have CEREX, we didn't have lasers. But what's really happened in hygiene visit, we've had virtually no changes. We've had certain things that have come into place like PerioWave, oral DNA, but there's nothing that's really helped to control the infection. And even lasers, the challenge in using lasers and decontamination is they clean the sulcus, but they don't clean the mouth. They don't clean the cheeks, the tongue, the back of the throat, the tonsils where these bacteria are harbored as well. So let's lay some of the assumptions aside, and we'll have some fun. 75% of our patients have gum disease. Imagine them walking into your office and there's a sign above the door that says 25% of my patients are healthy. Or you go to see a lawyer and it says, I lose 75% of my cases. And yet they're seeing us twice a year. And the problem is we're treating their teeth rather than their gums. Why do we use scalers and put them in infected sites and then use the same instruments in non-infected sites? If we fell down and broke both wrists, and if we had an infection on one side but just had a break on the other, we would never allow the surgeon to use the instruments from the infected site on the uninfected site. So why is it okay to do this for gum care, but it's not okay to do that elsewhere? And our challenge is we don't know the patients have infection. We don't know where the infection is until we start scaling. And so what I'm recommending is that you use a technique called the papillary bleeding score, which will identify where the bleeding is. And then you can irrigate those tissues with chlorhexidine or a hydrogen peroxide with a piezoelectric scaler or Cavitron to disinfect the site before you start scaling. In doing that, you reduce the biofilm load, and you help to make that area healthy so you don't transfer the infection. Are your patients
healthy? You made reference to a term I was unfamiliar with about scaling. What was that term you used?
Did you meant the term irrigation, Danny?
No, I'm sorry, I missed it. It was and then I didn't even get the context, but you just said, that's all right. I mean, you're probably going to elaborate on it later. You had an index or some kind of a measure, I think.
Oh, papillary bleeding score. I am going to elaborate later. That's where you use a soft pick or stimulant to press between the teeth. Healthy tissue never bleeds. The only time bleeding is normal is if you're menstruating or having a baby. Beyond that, there's an issue. And if the tissues bleed when you touch them like that, it means there's infection. If the tissues are sore, it means there's inflammation. That means they have gum disease. And if you can demonstrate that to the patient before you scale, then they understand that they have the problem and it's not your instruments causing it, and so you don't get blamed. So then we want to get our patients with shallow pockets with no bleeding, and we want to get your practice into the 25% range because you can't heal everybody, but eventually you will try. Avoid the words little and watch. You should consider them capital F words. Watch stands for, wait until the client hurts. And do we use these to describe bleeding? Because if we minimize bleeding, we minimize the treatment that the patient requires. So any bleeding anywhere is not normal, and we have to change our assumptions and strive to get there. Are your patients upset when the gums bleed during a hygiene visit? And if not, why not? A friend of mine went to a ski resort, and when I asked him how his day went, he told me he had a terrible day. I said, what happened? He said, Jim, I went to the washroom about 10 o'clock. He said there was blood in the urinal. He said, I left right away and drove 2.5 hours to the emergency room in Toronto to get it checked out. Why are our patients, when they're bleeding and spitting in the sink, why aren't we doing the same thing? Why aren't they doing the same thing? Do the patients understand the oral systemic link? Can your team present periodontal care as a medical concern? Are you comfortable doing this? And if not, why not? If you're not going to do it, who's going to do it? and our patients are depending on us to take care of them and to give them this information. Can a team member diagnose periodontal disease before it's apparent? We're talking then about subjective or objective tests. And so subjective is everything looks good. I like the way things are. Everything appears healthy. But does your doctor talk about your blood pressure like that? Or does doctor say your blood pressure is X? You weigh this amount. Your urine tests show this. Your cholesterol levels are this. And based on that, I'm going to do this for you so we get you down to those levels. So we'll talk about objective tests that you can do. An easiest one is to diagnose, is to disclose every patient that has periodontal disease, and to see the extent of the biofilm, to measure pockets and give them the numbers, to count the actual number of bleeding points, not to just say you have bleeding, and to keep that score and compare it after therapy, to do the papillary bleeding index that I mentioned a few moments ago. And now you have parameters that you can measure with and see, do they have disease and have they gotten better or not? Can they describe how you get periodontal disease? I want you to imagine if I say to you, can you explain to a patient where the first bacteria came from? Think about that for a moment. And patients, when I ask them, do you know where you got the first bacteria, they say from food, from utensils that went in my mouth, and they don't understand it comes from kissing, that from the mother's first kiss or the father, and saliva transfer are the bacteria that cause periodontal disease. And as such, when they kiss those that they're close with, they're transferring this disease. And when you talk about that after you've demonstrated bleeding in the mouth, and then you ask them if they are able to, if they feel that this would be good to be kissing with bleeding like this, there isn't a single patient that doesn't say, how do I stop the bleeding? But you can't do it in a scaring way. You have to drop the S and get to a caring way, and you have to approach it from an informative way as opposed to trying to scare them into care. If you're hesitant to discuss this, why are you hesitant? It's the truth, and patients want to know risks and how to reduce risks in relationships. When I graduated from school until about 2007, I had no idea about what caused actual breath odor, what therapies could treat it, what influenced it. And when I met Ann Bosey, who was the person that basically invented the orovital system, she mentioned to me the same bacteria that cause gum disease cause periodontal disease. And if you can control those bacteria, then the breath odors go away. She made me aware, as we'll discuss later in the presentation, of the factors that affect breath odor. And out of that, when she told me that she was able to treat with a certainty over 80 to 85% of patients with breath odor within a few weeks, I asked her how the gums got, and she said they got really healthy. And from that day, I tried to transform Orovital from just a breath care company to one that treated periodontal disease and breath odor. Can we offer effective home care instructions patients will adopt? So the usual thing when the patient sits down, the hygienist says, have you been flossing? Well, that's kind of like asking somebody, have they been using deodorant? And it's not the proper way to approach any adult. The challenge is we tell them to brush their teeth and to floss. But think about this. Does it really prevent periodontal disease? If their gums are bleeding, if you were to ask them to brush their gums as well as their teeth or to brush at the gum line, the intent of the therapy would be totally different from trying to brush on the occlusal surface. And so I tell my patients to brush at the gum line, to hit their teeth and gums, because when they hit the gums, they always hit the teeth. But if they hit the teeth, they don't necessarily hit the gums. This will dramatically reduce the amount of bleeding on buccal and lingual surfaces. Then we tell our patients to floss. How many of your patients floss? About 8% of them. And when you floss, if you think of floss adapting to a convex surface like the outside of a tooth, it does a perfect job of adapting in a C shape. But there's a gap between the tooth and the gum, between the teeth, and the gum is a concave shape. Now we know that you cannot floss the inside of a bowl. And when I ask patients, can you floss the inside of a bowl, a concave shape, everybody says no. I said, so do you think then when you're flossing, you can pull floss against the tooth, go across the space, and push the floss at the same time against the gum to remove the biofilm on the gum because we're trying to treat periodontal disease? And they all say, no, it's not possible. And if you think about it, when you start using soft picks and stimulants, most of your flossers are going to bleed. And they're going to bleed because the biofilm is adherent to the gum as much as it is to the tooth. Our challenge is we assume in doing those therapies that the tissues are going to shrink from a trauma. But what actually happens is the gums go from a beer belly to a six-pack abs, and they shrink getting healthy, because anywhere else in the body that you rub tissue, tissue calluses. And gum gingival tissue is no different than tissue elsewhere. It doesn't recede with rubbing. It thickens. So when we look at the mouth then, we're the gateway to the external world and the other way around, and this is where the oral biofilm is. And we have to remember that what happens in the mouth doesn't stay in the mouth. It's connected through the arteries of the body, the highway of the body, to the rest of every organ that's there. And what happens in the mouth affects the entire body. When we were in school, this is the typical slide that we saw, and we can see calculus, which we work hard to remove. We see planktonic bacteria floating around. But this bacteria is not organized in a biofilm, and there really is no organized biofilm. There's no granulation tissue here, and I'm not seeing all sorts of signs of redness and inflammation. And so what we need to be doing is cleaning this area here, and we're going to assume the teeth get clean, but we have to get the biofilm off. Remember that these ulcerations that are here, if we were to take the gum and peel the gum to the right, we would see the wounds, but the patients can't see them. They don't feel them because there's no fever, there's no pain, and there's no swelling, the hallmarks of infection, and that's how spirochetes stay under the radar. But through these microabrasions, through the blood vessels go the inflammatory products and the bacteria with bacteremias. This is the model that we have to keep in mind in treating our patients. So biofilm is normal. It adheres throughout our body, and it's only if you have it as a wound that you have a problem. And we have to keep in mind the concept of surface area. So you have 10 bleeding points or 100 bleeding points. There is a difference. So each person then has a unique biofilm composition that is theirs. The response to treatment will be different. If you end up having a lot of amoebas, you're going to have a whole different problem. If you have a lot of spirochetes, you'll have a lot of problems. If you have a lot of P. gingivalis, you'll have a lot of problems. If it's more strep mutans, you'll have decay. It's the bacteria, after we scale, regroup in 3 days. And so if we haven't cleansed the mouth of the pathogenic biofilm and we leave a reservoir, they will return, multiply, and they're back to normal virtually after 3 days. Now I have 8,760 hours down here because those are the number of hours in a year. 2 might be the average for most patients in a dental office, although it should be closer to 3 or 4. But if these 2 hours are the only therapy they get in cleaning effectively during the 8,760 hours, your patients are going to be bleeding every time they come in. But if we can transform this experience into them working for 8,760 hours, we will make a difference. It was only in 2011, I think, a study came out that suggested that P. gingivalis is the initiator of periodontal disease. And if you think of how long we've been treating periodontal disease and we weren't quite sure what was the initiator, these are new studies that are coming out. And what P. gingivalis does is it blocks 2 receptor sites on the white blood cells, and it causes chronic infections. When it blocks those sites, you're no longer able to see they're no longer able to see the P. gingivalis, and so the P. gingivalis is able to multiply. Spirochetes are commensurate bacteria that come in afterwards. We know they have a strong association with bleeding tissues and systemic inflammation, and these are bacteria that we have to have no place for in the patient's mouth because they will not stay there. They'll spread through the body. We've talked about the microulcerations allowing these bacteria in. And the takeaway is that you need to test or consider testing for these bacteria. Consider using the antibiotic rinses that I'll discuss. And sometimes oral doses are needed if the patient has significant periodontal disease and the rinses alone have not done it. We want to decrease the oral systemic link. So they're serious wounds. If you fall down and scrape your hand, you can see it. It bleeds on touching. It hurts to touch. And it heals in 7 to 10 days. But I talk to my patients about periodontal wounds never healing. As long as they have the infection, the inflammatory products and the bacteria are affecting our immune system, are getting into the bloodstream and eventually will find a place in the body that they cause problems. And so this concept of 24 hours a day, 7 days a week, 365 days a year for decades. So when I look at 20 bleeding points now and looking at a wound the size of your thumbnail, imagine an ulcer like that for 20 or 30 years. You wouldn't let it go. When we scrape and clean teeth and gum tissue, don't mean to be crude when I say this, but your physician doesn't take steel wool and scrape a wound to clean it. They disinfect it. Then they'll give you a salve or an antibiotics if it's required. So scaling can do nothing for biofilm except disturb it. It does not treat periodontal disease, the cause of it. It does treat the symptoms. So then we tell the patients to go back and see 6 months, and we'll see how the wound is doing. You would not leave your physician's office and allow him to keep checking every 6 months if you had bleeding coming from your ear to see if it stopped. You'd want to know it had stopped. What referrals and tests and medications would a physician prescribe for a non-healing wound? Should we be treating it like them? Why do we treat gum disease differently? I think part of the problem is our patients are conditioned to accept care a certain way. And to make this type of transformation, you have to have a vision of how you're going to get them healthy, and you have to know that the treatment therapies we're recommending are going to work. So if you assume a bleeding point is 2 to 4 square millimeters, 50 bleeding points is about the size of your thumbnail. That would not be left long in the body. Imagine them as bed sores, and this is how I talk to my patients, that they don't heal. These invisible, asymptomatic wounds are serious wounds. With gingivitis, where you have, if you go across 28 teeth, buccally, lingually, interproximally, a wound size the size of half the palm of your hand is not inconceivable. Severe periodontitis, you're looking at something that is 4 to 6 square inches. And this is the oral systemic connection. And someone that has a wound like this for decades is going to have an oral systemic link, is going to have a heart disease, diabetic connection. And these are the areas that we can intervene and make our patients healthier. Bacteremias, the study looked at do they occur after scaling? And they indicated that bacteremias are frequently, and they occur immediately after scaling. So again, the concept of irrigating the tissues before you do any scaling to try and reduce the biofilm load so that the patient will heal quickly and you don't spread the infection in the mouth. But what are the implications for bacteremias if the patient's doing their own home care? If they've had hip and knee replacement, the patients on a daily basis could be putting themselves at risk. And so when I see patients with valve, hip, knee, and replacement issues, I talk to them about how important it is to get healthy every day so that they still may need to take antibiotics if they're recommended, but they're not making themselves sick on a daily basis. So gingivitis does contribute to bacteremias. Lawyers know this. The public knows this. And we always talk about the oral systemic link. And in cases of pneumonia, 10% reduction in deaths from pneumonia in nursing homes if their teeth were brushed 3 times a week because the bacteria grow and are inhaled. We know that with cancer, pancreatic cancer is virtually associated with a bacterial profile that matches periodontal disease. We're all aware of the link with diabetes, cardiovascular disease I'll discuss in a few minutes, Alzheimer's as well. We've heard about low birth weight, preterm delivery, spontaneous abortion. And this is related to the inflammatory products that are released. Osteoporosis, I'll talk about that in a moment. Rheumatoid arthritis. Does some of rheumatoid arthritis begin or get initiated from the damage that occurs in and around the mouth, where our body starts to react to our own cells and cross-reacts then with the cartilages? Lifespan and mortality, that's a huge issue, and this is a study that discussed that. In Sweden, they followed 1.2 million people out of 9 million for 24 years, and they looked at the age of 40, if you lost a molar, when did you die? The study took out all of the other factors, and the only factor that remained that affected the lifespan was periodontal disease. And so women died an average of 31 years early, and men 31 years early if they lost a tooth by the age of 40. Think about wound size when we're saying this sort of thing, where you're able to see a wound that size and the effect it has in the whole body. And so untreated gum disease is killing people. They called it an epidemic that needs to be taken care of. We're taking care of these types of patients as well. So the oral systemic link in spirochete diseases. We're all aware of periodontal disease. We've talked about 75% of our patients being infected. Syphilis is a spirochete disease as well. It's a historical crisis, but we know if you get syphilis, it takes about 40 years to die. Periodontal disease takes 30 years before you start losing teeth. We know you will die from dementia, and we know 100% of the brains will have the spirochete in the brain. Lyme disease is a tick bite, and in the saliva of the tick in its mouth are spirochetes and other pathogens. It's a present-day crisis. When these bacteria get directly into the bloodstream, they cause widespread destruction. These patients are on oral antibiotics in massive doses for years. Many of them develop dementia, about 20% of them, and 20% of them die 25 years later from dementia that's identical to a syphilis dementia and an Alzheimer's dementia, and 100% of them have this bacteria in the brain. So we have a case of two bacteria causing dementia. Alzheimer's is being called a neurospiroketosis, and 93.6% of all brains autopsied contain one of 5 spirochetes. They happen to match the 5 oral spirochetes associated with periodontal disease. And so it wouldn't be hard to imagine these spirochetes working their way through the bloodstream or up the nerve endings and sheaths and invading the brain. And so when I see a lot of bleeding, and I see someone losing their teeth at 40, I think lifespan. When I look at a family history of Alzheimer's, I start thinking about the bleeding that's occurring and wanting to get to zero bleeding. And patients don't want to get into this. If you can help them prevent Alzheimer's, they will do what's required. Heart disease and pathogenic bacteria. They looked at when you'd had a heart attack, they looked at the blood clots, and they said, what did they find? They found in 49% and 45% live bacteria. They happen to be periodontal bacteria. New studies are showing an increased link with periodontal disease, but it's not related to atherosclerosis. It's related to the thickness of the artery walls. And so P. gingivalis will get through the endothelium, will open up the endothelial cells. That allows the low-density cholesterol in. From there, you get mast cells going in. You get inflammation and swelling of and thickness of the wall, and then the wall ruptures. A blood clot forms to heal, and you have a heart attack or a stroke. And so what they're saying is when they took a look at the thickness of the wall, causally related to periodontal disease was P. gingivalis, and the pathogens were occurring in 3-millimeter pockets, and this was significant among all other factors. So gingivitis does matter for people that have heart disease. And they direct relationship subclinically as well as clinically to periodontal disease. And subclinically it was the level of P. gingivalis found in the wall, not the extent of the heart disease or the periodontal disease in the patient. And so we need to diagnose if patients have these bacteria, and we have to get rid of them if we can. This shows a patient that's had a Panorex, has a history of high blood pressure. Do you think this patient could be affected by periodontal disease as far as their heart disease goes? And so this is not uncommon. And when you see something like this, we have to take care of it swiftly, but we don't want patients to get there. That's the focus of this particular seminar. What are our risks? Dental splatter. 21% of patients had MRSA on their lab coats. The micron's size is smaller than the masks that we wear. And so we want to control the infection so we can decrease our risk. There's been several cases where people have been refused entry to grocery stores where they're buying meat and they're buying vegetables and fruit because they're wearing clinical attire. And the stores were concerned about that being transferred to the food that could then be transferred to the people that enter the store. So dental debridement is absolutely essential, but we know it doesn't eliminate the oral pathogens. And breakdown continues over time, the 2 hours versus the 8760. Verbal skills are required. Consider the rinses and consider it a serious infection, and it's important. Offer antimicrobial testing. The difference with the orovital testing is we actually take the subgingival biofilm, and in 3 or 6 sites, depending on what you want to do, you get a testing for site-specific locations versus testing the saliva, which does not represent as accurately what's happening under the gums. And we offer ongoing coaching for hygiene mastery, not just teaching you how to clean teeth. 5-step program, diagnosis. We're talking about periodontal charting or PSR, at least if you're not able to do it, to begin every routine hygiene visit. We want to count the number of bleeding points on a yearly basis. We want to compare it. We'll get into the papillary bleeding score in a few moments. We want to disclose at the beginning of every hygiene visit. Why? Patients can't see biofilm. It's transparent. It's invisible to us. And we have no idea whether it's a thick adherent biofilm or a fluffy one that can be taken away with very light pressure. So until you disclose, we don't know what's required to actually remove the biofilm. When it's disclosed, you can demonstrate to the patient how to care for the mouth effectively, and they can see that they're being effective. Then we want to consider taking microbiological samples and go from there. Next, the treatment. Go through the scaling and root planing. Prescribe the non-systemic antibiotic and chlorhexidine rinses, and do irrigation if it's required to cleanse the mouth. Reevaluation appointment. Go through a reevaluation again to check the tissues, look at the number of bleeding points, pocket depths, papillary bleeding score, disclose, and at that appointment, polish the teeth. Don't do the polishing here. Patients consider the polish their final cleaning. And if you hold that off to the next visit, they're more likely to come back and have it done. Remember what a physician would do, and this is how we have to treat. Maintenance. The patients need ongoing maintenance rinses to help rebalance and keep the biofilm under control with the mechanical work that they're doing. It's a prerequisite for oral health. They're hearing it in advertising through Crest. I'm seeing it all of the dental magazines. We offer rinses that you can prescribe to them that can be delivered to your office, so they won't find them in the stores, or you can recommend ones that are in the stores, and I'll recommend them in a few moments. And then continue with the monitoring of your patient as is required, and the regular hygiene interval according to the disease they have. So who are candidates for care? Those with a colorful health history, signs of gingivitis and periodontal disease, breath odor. Periodontal charting results show 5, 6, 7 millimeter pockets. Bleeding on probing score where they have more than 20 bleeding points perhaps. Infection shows on the microbiology report. Patients that require periodontal surgery. Doesn't it make sense to get rid of the biofilm that causes periodontal disease or bring it under control before doing surgery, before placing implants, before perhaps working on patients who have osteoporosis and are taking medications for it, the bisphosphonates, to reduce the outcome of having problems. Patients that have mucositis or periimplantitis, and doing that type of therapy before you actually do any therapy in terms of gum surgery there. Patients with a lot of crown or bridge with inflammation, or patients who have difficulty cleaning their upper anteriors, you're doing 5 or 6 crowns, consider using a rinse 3 days before you do the preparations. They're in the rinses during the preparation and during the temporization, and when they come back, there's no bleeding in the gums for you to be able to bomb things in place. All patients that have hip, knee, and valve replacement, especially valve replacement. Now, part of our challenge is one of diagnosing. If we take a look at this slide, we can see there's a tooth, and it's broken. And in about 10 seconds, we know they bit into something, the amalgam expanded, the pulp is likely not affected. We don't want to do a composite. We prefer to do an onlay or a core and a crown, depending on how you would treat it. And we know it will last 15, 20 years or longer. We know what it's going to cost. We know how long it's going to take. Why can't we do the same for periodontal disease? Does this mouth look healthy? It certainly doesn't. But how will we predictably treat this patient in a few appointments and get them to a stage where they look like this patient? But can we see the gingivitis there? Can we see the bleeding there? Can we see the infection and inflammation, or are we going on subjective symptoms, subjective signs, and saying it appears healthy, it looks healthy? This is the patient that made me trip and realize that I did not know how to diagnose periodontal disease properly, and I had to find a different way of doing things. Because when I manipulated her tissues and just told her she had the most beautiful smile, and then she had the type of bleeding that you'll see in a few moments, I thought to myself, why wasn't I able to diagnose the problem? And so we all do accidental bleeding scores. It's a late diagnosis. We cleaned her teeth. This was the bleeding. I felt terrible because a few moments ago I told her how nice her smile was. And really, She looked like that. That's how she should have appeared to me. That's how she looked. This is what I got when we started scaling. So that's a papillary bleeding score, but it's being done accidentally with a scaling instrument. This is what her toothbrush looked like. When you show a patient this, if you've discussed how they get gum disease, kissing transfers gum disease, a young 24-year-old lady sees a toothbrush like this, they viscerally do not want the bleeding. But can you offer them a solution that will get rid of the bleeding in 2 weeks? That's what we're trying to do. And it isn't just about brush your teeth and floss. As we've discussed, that won't work. It's brush your gums and teeth and use some picks. So what's the papillary bleeding score? I tend to use stimulants or soft picks. A patient that has some obvious signs of periodontal disease here, when we put a soft pick or stimulant in, we get tremendous amount of bleeding. And if before you scale the patient, you can demonstrate this degree of bleeding, then the patient is more in a mood to listen to the fact that they have a problem. If the tissues are tender and you've discussed it ahead of time, tenderness means inflammation, and you can rub against this tissue or against their lip or chin and it doesn't hurt, they know that it's not the instrument causing the problem. If you've discussed periodontal disease, relating it to their health history, to how they get it and how they share it, at this point they're thinking, I have the problem, I'd like to get rid of it. This is the 10-second test to show patients they have disease. So what is a papillary bleeding score? I'd say 0 to 3, no bleeding. This is where all of your patients should be. The mouth is healthy. This is more important in actual fact than the number of bleeding points, and I'll get to that in a moment. So your goal here is to never have bleeding when you use a soft pick or stimulant between the teeth. On the 3rd day of using it with firm pressure, the bleeding will stop for most patients. Light localized bleeding, you're going to disclose the patient, suggest improved interproximal cleaning. They usually have to push more firmly. You might suggest a maintenance rinse. If you get to moderate generalized bleeding, you're going to recommend they do some testing to find out what type of bacteria, the levels of the bacteria, where they are in the mouth. You're going to consider recommending antibiotic and antimicrobial rinses because you want to bring that infection under control. And if you get to heavy, spontaneous, generalized bleeding, as we're seeing here, you'd want to always recommend testing and the antibiotic and antimicrobial therapy. This is a patient that I flossed, and I passed the floss 5 or 6 times firmly interproximally for this patient. He was 40 years old. There was no bleeding on probing, nor was there much with flossing. And yet in a moment, and there's the probing, and when I use the soft pick, that's the degree of bleeding that I see. And believe it or not, that's the degree of bleeding you'll see on 50 to 60% of new patients or your existing hygiene patients if they're not using something like a soft pick or stimulant to clean in between. So be prepared to discuss this before it happens and tell them there'll be a solution to it and that's easy. Bleeding on probing score. I aim for less than 10. And why do I say less than 10 and not 0? If a patient's trying to clean 28 to 32 teeth, and it's almost impossible for them to clean 3 to 4 millimeters subgingivally entirely around that entire circumference. If they're in the range of 10 or less, they have a very healthy mouth, as long as the papillary bleeding score is 0. If the papillary bleeding score is a 1 or a 2 or a 3, this trumps the number of bleeding points. 10 to 20, areas of concern, disclose again, suggest a maintenance rinse, start considering the others. By the time you get to 30 plus, it's a serious disease. Reevaluations required. Some antibiotic and antimicrobial rinses are suggested. The best disclosing solution is something like a 2-tone, and there is a 3-tone now. If you imagine, why do we have to disclose? If you walked into a room and it was full of toys and I asked you to clean it up, you'd have no problem, or not to step on the toys. But to put a blindfold on, it would not be easy for you to do the job, and odds are you would step on them or you might miss some toys. And when the patients look in their mouth, unless they're disclosed with something like this, they can't see the biofilm. And as such, they don't know why they need to clean at the gum line. So it shows invisible biofilm to the patients and professionals. And in a moment, I'll show you a couple of patients where this is critical to do. It's necessary to demonstrate its presence, and when it's there, you can then show them how to clean it off and have them demonstrate to you that they can do it by them actually doing the cleaning themselves. So simple words like, I'd like to show you where you're having some trouble reaching, or can I show you where the bacteria causing the infection and bleeding we saw in your mouth is? Everybody says okay. Don't ask them if they want to be disclosed. Nobody wants to be disclosed. So this is a young man I've been taking care of since he was 3, and he's got recession in this area. He's got inflammation there. But the problem is his lower lip interferes with cleaning, so we had to talk about keeping his teeth together, pulling his lip back, and then we disclosed him. And guess what we saw? Biofilm accumulating not super gingivally, but right at the gum line, cervical margin. And we were shocked because we did not see that biofilm here. And yet if that exists and he has surgery, he may not be able to maintain it. So we need to disclose in cases to show patients what's going on. This is the patient that's had extensive crown or bridge work, implants done, and she's got swollen tissues, but I don't see any biofilm. And then I disclosed. And look at the biofilm here coating the tissues. So the statement, I'd like you to brush at the gum line, I think you can see how important it is, because this is where patients live with brushing. And they can forget brushing from here to there for the rest of their lives, because the lip, tongue, and cheeks are going to do the work. This is where the biofilm lives. This is where we have to get them brushing at the gum line. We do testing with microbiology, and we use a slide. It's divided into 3. We go through details later of how you mark it, but you're going to take a soft pick or some floss, and you're going to apply it to these 3 locations. If you wanted to test the back of the tongue to see if there's breath odor coming from the back of the mouth, you put the mirror against the back of the tongue, apply it to this area, and then pick a maxillary and mandibular. We do offer it in 6, where you can do 2 parts of the tongue and individual quadrants, and you'll get a microbiology report back that looks like this. This shows 6 sites, and we do show before and after for the same patient if you decide to do it. This is read from top to bottom more than it is from left to right at first, and this shows the type of bacteria. So we do show gram-positive bacteria because you're going to be seeing strep mutans and things like that as well. We do show the gram-negatives, but we don't show the individual bacteria. So in other words, these are your P. gingivalis. These are your spirochetes. Vibrio are very bad. We'll show you yeast. We'll show you amoebas. We'll show you white blood cells. And this is something oral DNA does not do. And if you have these bugs, you have a parasitic infection, you need metronidazole to treat them. We take a look at colors, and the colors, just give me a moment, the colors show healthy, concern, and infection. And so you're able to see as you go along with treatment. Another slide, I'm not going to get complicated today, the changes that occur. So objective tests measure the pockets. The challenge is we know this is a past history, and it doesn't show disease. We don't know anything about the physiology or biology of the pocket, whether it's infected or stable. So you have to count the bleeding on probing score, have to count the numbers and compare, have to do a papillary bleeding score, need to disclose, and you do it in this order. We talk to the patients about doing objective measurements. We give them their score. We do microbiological testing. If we find that these scores would be warranting it, we'll do an odor assessment if there's a concern about, breath odor, and that can be done in the usual way we assess odors, or you can use something like an oral chroma or a halimeter to measure the compounds that are in the breath more objectively. And we always are going to do reevaluation and comparisons and further care recommendations if the patients aren't healthy. Step 2, we're going to complete the scaling, the root planing, prescribe the rinses. Don't polish the teeth at this stage. Using the rinses. The rinses are used 3 times a day for 30 seconds, spit out, and there's no rinsing for 30 minutes. You don't want to dilute the solutions. We suggest they be used morning, lunch, mid-afternoon, and night. Most patients may end up doing this around supper time and this before they go to bed. Use the bottle till it's finished. We follow up with antimicrobial, and antimicrobial is chlorhexidine, and you're looking at a 2% chlorhexidine that is non-staining. And non-staining is important because we don't have as many surfactants in it, and we have metal ions that affect the way that it binds to biofilm. And with the techniques we teach our patients, there's less biofilm, so there will be less staining for that reason as well. It's used for 2 weeks because when you use the antibiotic, you're going to kill the gram-negative. You get an overgrowth of gram-positive. The chlorhexidine will kill and bring that under control. Again, rinsing twice a day for 30 seconds. No other rinsing for 30 minutes. We do it for 14 days. And then you need maintenance rinses. Maintenance rinses, such as we have CDLX. You would know this as something like Closis. We have CPCX. You would know that as Crest Pro Health. And we have Smart Mouth, which you're aware of, that you can buy in the drugstore as well, and it can be sold and shipped to your office if you'd like. So these products can be sold by you in your office, or you can recommend the equivalent in the drugstore depending on how you like to run your practice. These are what the rinses look like. They're compounded rinses, so this would be the antibiotic, the antimicrobial, and this antibiotic is also in a cream form. And I'd like you to think Arrestin, I'd like you to think Atrodox, that you can apply this locally into the pocket, but not only you, the patient can dip a soft pick, a rubber tip, or floss, and can apply this locally to the infection to start doing site-specific treatment. And it's very inexpensive, and it provides a nice way of them taking control of their problem. It's used a lot where patients have odors between the teeth. That's how we started using it when you're doing breath odor treatment, and then realized it could help to resolve a lot of mucositis, periimplantitis, and localized 5 and 6 millimeter pockets. This rinse here is compounded by a pharmacy in, we've got Habers, but it's actually in Buffalo, and it's shipped overnight to dental offices wherever you are in the States free of charge. It has to be compounded because it's a proprietary product. We have certified compounding pharmacies that do it, and as we expand in the business, we'll have them located in each state as we go along. So the rinses then are topical antibiotic rinses. They're colloidal suspensions. It means they're antibiotic particles. They're not a liquid. And the difference is, if you rinse with a liquid, you're going to get a spike of the antibiotic. You're going to get it washed out very quickly. But if you have particles, these particles are going to adhere to the cheek, the tongue, the throat, the gums, into the sulcus, and they're going to break down slowly. And as the particles break down, you get continuous release of the antibiotic for a longer period of time. Our rinses are actually half of what we would use in an oral pill. So we use metronidazole and nystatin in combination. I'll go over that in a moment. And the metronidazole would be at 125 milligrams versus 250. So we actually use, just give me a second here. We actually use half of the systemic dose, and none of it gets systemically. When you rinse with an antibiotic, you're going to get 3,000 to 4,000 times the concentration. Think about this, of the same dose in the saliva that if you took the same medication orally. So when you take a pill, it has to dissolve in your entire body. Very little of it is going to end up in the saliva. But if you rinse with it, 100% does. And as such, it exceeds the minimum inhibitory concentration needed to penetrate biofilms. That's why it works within a week or two to kill the bacteria. Oral doses cannot do it. Females in particular do not want to be taking systemic antibiotics for yeast infections. And most patients, if they can avoid systemic antibiotics for the change in the gut bacteria, will do it. So it's readily accepted by the patient. It's looked at as a non-invasive procedure. It's something they're used to getting when they have infections, and it's covered under a lot of medical plans. And even at that, it's about $120 for both rinses shipped to your office. Use 3 times a day for 2 weeks, a rinse and gargle and spit method. And the advantage, no systemic effects. On top of that, when you rinse with an antibiotic, you will have residual yeast in the mouth. This yeast can overgrow, and it can affect you systemically. So we put nystatin in, which will control all of the yeast infection. And what we also found is nystatin weakens cell walls of all bacteria, not just yeast, and it makes the metronidazole able to penetrate well. So you get good patient acceptance. Rinsing with the antibiotics will decrease the pathogens, and this is critical, the throat, the tongue, the teeth, decreasing the risk of reinfection. We don't think about this biofilm coming back into the mouth from other areas. So when you scale one quadrant, the next day the bacteria are coming from other quadrants back where they began. Whereas when you finish your therapy, whenever that is, an oral antibiotic rinse will decrease the pathogens throughout the mouth and in the sulcus as well, and we'll go into that in a moment. So preparations are compounded. Patients find it easy to use, and these are our rinses. For no particular reason, it's called FM4 with metronidazole and nystatin, and this is for periodontal disease and breath odor. About 4 years ago, we added amoxicillin to tackle AA, and it's used for more complicated situations or for patients that have more aggressive periodontal disease. Those that are going to have implant therapy before they have the implant surgery, they'd rinse for 3 days and then for 10 days after. Severe periodontal disease and bronch, which is bisphosphonate-related osteonecrosis of the jaw. Those that are on bisphosphonates are prone to that. TET2 is a tetracycline nystatin. This is used a lot for breath care if your tests show a lot of gram-positive versus gram-negative. This will kill gram-negative as well because tetracycline-based products, doxycycline, do that. And so it's a better tasting product. It's sometimes used for children. And these are also in adult and child doses, so that they do vary. This is the cream form of the antibiotic for localized applications. And when you see a patient with denture stomatitis in the mouth, they have a yeast infection on the surface of their appliance and on their tissues. If you were to apply this cream against the denture, and they do that for 2 weeks, the stomatitis will usually resolve. So another use for the cream. And then we have 2 types of chlorhexidine, a very low to no staining, one that might stain a little bit more. This is mint, this is non-mint. Depends on what flavor the patient wants. But it controls the streptococci, rebalances the biofilm after you've gone through an antibiotic. Venturi effect. How do the particles get into the sulcus? When you have something that comes along, there's a narrowing of the sulcus, things are drawn down, other things come up. It's the way wine is aerated, and the crevicular fluid drops, the particles are drawn in. You get 100% of the antibiotic to the depth of the pocket, and it's effective against amoebas, yeast, and the gram-negative pathogens. And as your pockets shrink with home care and with antibiotic, the antibiotic is able to reach further into the pocket as it goes along. Your rinses are effective. We see a 79% shrinkage of 4 millimeter pockets, 5s. We're seeing bleeding on probing down 87%, halitosis reduction of at least 80%. And so 649 patients were sent to the University of Patient Files, were sent to the University of Michigan. Walter Loesch was Ann's mentor at the University of Michigan, and his statistician did this analysis. It was published in the Academy of General Dentistry in 2013. Our p-value is 0.0001, which is 1 in 10,000. A good result is 0.01. So there's no doubt that oral antibiotics delivered in a rinse are effective at both halitosis and bleeding on probing reduction and pocket shrinkage. These are the sorts of things that you're typically going to see. This particular person was diabetic, had high blood pressure, had multiple 4 or 5 millimeter pockets, 73 bleeding points. Pretty well everywhere between his teeth that we used the soft pick and Stimident, things were bleeding. He was out of control. Literally 2 weeks later, we're down to 9 bleeding points. And if you take a look, you'll see most of the pocket depths are down within a normal range, except a few in this area here. This patient stayed like this for about 2 years, and then he got a lot more bleeding, but when we measured him, his pocket depths had remained the same. So will patients need retreatment? Possibly. But you do get infections in your bladder again. You do get infections in your lungs again. And giving an antibiotic once, rinse or pill form, doesn't mean you'll never get an infection again. If you get very run down, if your dog kisses you and has periodontal disease, if you get a new partner and you get transference, if you stop doing the things that keep you healthy, don't come and see the dentist. And my favorite statement is, bugs don't take vacations even though we do. You can have recurrence of disease. Which way do you want to treat on recurrence? Periodontal surgery or try rinses again? Rinses would always be the first thing that you consider. Step 3, reevaluation 4 weeks after the rinses. First rinse takes 2 weeks. The second takes 2 weeks, so that's why we're saying 4 weeks. Think of what's happening during this 4 weeks. The patient is using a brushing technique that's different, is using soft picks and Stimidents on a daily basis. You may have recommended that they use a rubber tip if they have periodontal issues to trace the sulcus buccally and lingually firmly to cleanse out that sulcus. You may have recommended a sulca brush if they have a lot of heavy, thick labial and lingual biofilm, especially with gingival decay and recessions. And they're focusing on doing that because they know they're going to be reevaluated in 4 weeks. It takes 21 days to develop a habit. If you wait for about 4 weeks, most patients are going to develop the habit by the time the reevaluation comes in of doing good home care. And if they do, they're going to see a significant change. It's going to be about a 30-minute appointment. You can finish scaling and polishing at that point, but you're going to complete periodontal charting, bleeding and probing, the papillary bleeding score. You're going to disclose. You're going to review hygiene techniques. If you see biofilm, you're going to help them reach the areas they haven't reached. And you're going to make oral hygiene fun. You're going to say, oh, you have the windshield wiper effect. And patients will say, what's that? I'll say, well, do you ever watch the windshield wipers? When they go back and forth, it always misses a little spot. And I said, watch me, a right-handed person brushing. When they go from the left side to the right side, just like a windshield wiper, always miss the lower cuspid, either left-handed or right-handed. And they go, yeah, I guess I do that. And you can make it fun. Or tell them that we need them cleaning under the fridge and stove better, that the biofilm is a thick, gooey mass. So you can't vacuum. You got to get in your hands and knees and give it a scrubbing. You need firm pressure. Compare post-treatment results and pre-treatment results. Additional care if required. If you still have remaining pockets, what do you want to do? Laser therapy, periodontal surgery, Arrestin, FM3 cream, refer to the periodontist. If things are stable, put them on a maintenance rinse, polish their teeth, reappoint them. Reappoint them at a shorter interval. If they've needed this type of therapy, we need to monitor them, and we have to make sure they stay healthy. Don't let them go back to 6 months. Shorten the visit interval. CDLX is closest, and the chlorine here gets into the mitochondria and affects the way the mitochondria breaks down protein, and as such, it can't produce the odors, and if they can't they can't metabolize protein, they don't produce as much odor because it's sulfur-based products that come from protein that we smell. On top of that, if they can't metabolize protein, they can't thrive and multiply, and so you help to control the levels of bacteria using something like this. CPCX is very similar to chlorhexidine and affects the ability of the bacteria to bond to the tooth surface, and it will work against gram-positive and many gram-negative, but also works against gram-negative because it stops the adherence of the gram-positive, which are the first bacteria that adhere. It's a good maintenance rinse for patients that use the tetracycline rinse. It's excellent for caries-prone individuals, and both of these we have added xylitol to, so this will work for both perio and decay. This will work for perio and decay, and it sweetens the rinse and makes it very flavorful as well. Smart Mouth is a combination of CDLX and zinc chloride, and zinc coats the bacteria and stops the absorption of protein. And if the protein isn't absorbed, again, they can't reproduce or produce as many odors. And if they've got the chlorine getting into the mitochondria and they can't metabolize the protein, they're even more affected. And so it's the only one that states 12-hour fresh breath, and something that we use for patients that have breath odor. These are ones we recommend for patients under periodontal care. Probiotics are a good idea to reestablish a healthy balance. There are many types. We could discuss that if you were involved in our program. Step 5, monitor your patients during hygiene visits. Identify areas, disclose, use the papillary bleeding score, retake the samples if it's required, talk to them about reinfection that can occur, retreatment if it's required. Osteonecrosis of the jaw. I just thought I'd take a minute. Our Royal College in Ontario, Canada, indicated that they felt that biofilm theory explains the etiology of 65 to 80% of all infectious diseases that we treat. That in most cases, osteonecrosis of the jaw secondary to bisphosphonate, the oral that you've taken for 3 years or IV that you've used for cancer therapy, prevents the adherence of the tissue to the surface of the bone where a blood supply can be established. And as such, the biofilm does not let the bone get covered over. Prevention and management can depend on the effective use of anti-biofilm modalities for gram-negative, yeast, and AA, and oral doses cannot reach the necessary MIC. New approaches are needed, and that's what they sent us as a bulletin. So at that point, we added amoxicillin to our rinse to tackle AA. We had nystatin for yeast, and we had the metronidazole for the gram-negative biofilms. And I got a call from our Royal College, and they said to us, you need to come in and talk to us. What are you saying about this? 2 days before I was to come in, after we sent our information in, they told me I no longer needed to come in. And so I use this therapy on patients that have been taking oral bisphosphonates for 3 years, where I have to do surgery or a history of IV, get them rinsing with the rinse 3 days before and for 10 days after to try and reduce the impact of these pathogens on the healing that occurs afterwards. Prevention is paramount, and our oral antibiotic that's delivered in a rinse will work, whereas oral antibiotics do not. So what do specialists do when they're going to do surgery for implants or where they're going to treat patients that have potential for osteonecrosis of the jaw? They prescribe amoxicillin 500 milligrams. Now, if you look at the spectrum of amoxicillin, it's going to tackle gram-positive biofilms. But if you're doing implant surgery, you want to tackle gram-negative biofilms. They're going to prescribe chlorhexidine. Chlorhexidine is going to target mostly gram-positives. And so think of the paradigm shift. We do what we do because we've always done it. But does it make sense to have that type of regime if you're trying to kill gram-negative anaerobes? Consider the FM4 rinse. Add amoxicillin. 100% antibiotic and antifungal therapy exceeds the MIC. Use it before and after. Now you still have to go back. And because the standard of care is amoxicillin, you need to prescribe amoxicillin as well. But you're going to use our 0.2 chlorhexidine versus the 0.12 that stains. You won't have to clean the patient's teeth afterwards. You won't have to spend the time and taking care of the patient for a rinse that you've prescribed, and they don't want to pay to get the stain taken off. And you're going to provide a much more effective rinse that is killing the bacteria more than 0.12.
Jim,
Moving into breath.
Question for you.
Yes.
Just a quick clarification. You said you would recommend the 0.2 concentration of chlorhexidine instead of the usual stain 0.12?
That's correct, Danny. 0.12 is the standard dose that's used. Anne did a study when she was treating breath patients at the University of Toronto, where she did her master's degree in breath odor. And they started using 0.2 to help these patients control their breath odor. This was before oral antibiotic rinses were being used. The pharmacist changed it back to a 0.12, which is the standard because he felt this was too high. And to a person, the 20 patients who had been changed within 5 days called back up and said, my breath odor's returned. And so 0.2 is a much more effective level to use, and that's what we recommend.
Well, I could see for breath odor, it seemed counterintuitive that a lower concentration would lead to staining, whereas another one would not, the higher concentration. But maybe that's not what you're saying. You said that 0.12 is, go ahead.
What the 0.12 in efficacy is not as good as 0.2, but the other factor is ours is non-staining. So whether you're at 0.12 or 0.2, you don't get the staining.
Right. So it's the formulation. It's not the concentration.
It's the formulation. It's both the concentration and the formulation in the way that it's compounded that give the results, not just one or the other.
Understood. Thank you.
One of the longest words in the English dictionary is supercalifragilisticexpialidocious, and when it came to talking about breath odor, I thought this was a funny slide to show. I remember it just seemed humorous to me, and so let's talk about breath odor. These gases are harmful to our health. When we look at them, these gases are controlled in industrial plants. Things like hydrogen sulfide mercaptans are not allowed to be in the air for us to breathe. Methyl mercaptan is really the periobeth that you get. It causes rapid loss of sense of smell because it coats the olfactory nerves, and patients can't smell their breath and can't realize they have breath odor. It has harmful effects on the central nervous system, and chronic exposure does cause lung damage. The levels that you'll measure when you start using an oral chroma would be above levels that would be considered safe for you to breathe in normal air. And so patients who have significant breath odor are at risk for health effects related to these. On top of that, volatile sulfur compounds open up the bonds in the endothelial cells and the cells that line them out and allow bacteria to penetrate. So they facilitate infection as well. Hydrogen sulfide is the rotten egg smell. They put it into natural gas so you can smell it. Again, rapid loss of smell on exposure, and it can cause unconsciousness, even death. We see levels in the range of, 1,000 parts per billion in patients that have really bad breath odor, and you should be less than 125. Again, dimethyl sulfide is a cabbagey type of smell that you get, a perio breath as well, and these are the odors that you're detecting when patients have breath odor. We tend to assume that patients are okay with breath odor, but there are psychological effects. They have neurotic behavior. They rinse their mouths with mouthwash 10 to 12 times a day. They floss and clean between their teeth constantly. They carry breath mints and gum with them. They're socially withdrawn, and they have their hands over their mouths. They have very poor self-image. I've treated personally about 5 children under the age of 8. One of them goes to school with my grandson, and the kid has been teased terribly in the playground. And this particular child cleans their mouth like anybody else. I have another patient, 4 years old, a patient of a gal who is a hygienist. She's been fastidious about making sure this patient's mouth was clean, and yet this patient still had breath odor. And these patients had been to see specialists, and everyone said it's not your mouth. Everything looks healthy. We can't find anything in your sinuses, your lungs, your stomach. We don't know what it is. There's a lot of stress related to this, and the stress causes more breath odor for patients as well. So healthy populations can have breath odor. It's an infection. The same bacteria that cause periodontal disease cause breath odor. Healthy patients can have breath odor because the biofilm can be just between a few areas in their mouths, or it can be at the back of the tongue as it goes down the throat in a heavy biofilm. It can be in the tonsils and tonsillus. And good oral hygiene with a few pockets can still give you breath odor. It can be an imbalance in diet to do with drugs, hydration, poor nutrition, and stress. And this is why we started doing biofilm sampling to take a look at where the odors were coming from, where were these bacteria. And we've done about 20,000 slides over about 15 years and have good experience with understanding before and after treatments. Cryptic tonsils are the little things that you see in the tonsils, are the yellow things. And patients will try and squeeze these out, or they'll ask you to try and get rid of them. And when they come out onto the tongue, they give a foul taste. When they rinse with the antibiotics, they might need 2 treatments to take care of these types of things. Their mouths improve tremendously. They feel more confident. If you have patients that have strep throat, that have really bad tonsillitis, rinsing with the antibiotic mouthwash at the same time as the oral medication will significantly improve the healing and reduce the symptoms for the patients. So when you have breath odor problems, you often have bad taste and bad smell. The reason for the bad taste or inability to taste is the odors dissolve in the saliva. They cover the taste buds, and you can't taste. The odors get into the olfactory nerves, and you can't smell, and the patients can't smell their own breath. The only way to smell your own breath would be to lick your wrist, blow on it, to dry it, and then smell it. You can help patients smell their breath if you want by taking a mirror. If you think it's coming from the back of the throat, put it as it goes down the throat, dry it, pass it under the nose. Medications that dry the mouth will contribute to breath odor, but it's not causative. It contributes to it. Poor meal patterns where people are eating too high a protein or not eating enough food will cause it. Stress tends to dry the mouth. Patients that are dehydrated get an overgrowth of bacteria. Certain times of the month, menstrually, women will have hormone changes that make breath odor worse. Breath odor is worse in the morning because the mouth is dry at night, particularly if you've had a lot of protein the day before. And patients are thinking this is coming from their stomach, from their lungs, from their sinuses. And we get the patients coming in, they say, everyone says they don't know where it's coming from. 95% of odors come from the mouth. They don't come systemically. So we have 3 appointments where we will identify the problem, 2nd appointment to confirm the success of treatment, and they actually get a 3rd maintenance appointment, and patients will pay about $950 to $1,050 for these 3 visits that take 2.5 hours with the hygienist, and we can predictably get them healthy. So what have we discovered? That we have new choices for treating gum disease and breath odor. They work predictably and simply. We can present care, and this is key. We have to be able to present and sell the disease and the treatment. The disease is serious, and the treatment is easy and predictable. We've got new information, and that's the best thing you could say. I just got some new information I want to share with you. And we're going to try and get to the point where your gums never bleed. Let me see if your gums are a concern and how we can help you get there. We're giving you options that are scientifically valid. And compare this to the standard of how you're doing things now, or if you were a patient listening to this presentation, how would you want to be taken care of if you go to work tomorrow morning, or if you went into the dental office tomorrow morning? Because every single patient I talk to, I meet them at the church. I meet them when they, friends that come by, and I start talking to them. They sit down and have a 10-minute discussion with me, and to a person they say, why didn't somebody tell me this? I didn't know that information. I'm going to talk to my dentist about getting this type of therapy because it's what I want. And you'll have a great opportunity to grow your practice as you seem very knowledgeable and can offer treatment that patients want to have. Comparing our system to other systems, just quickly, we're looking at cost, patients accept them, whether or not you're treating the whole mouth or localized areas, whether you're using oral or rinses or oral systemic doses, how you're testing the biofilms. So oral DNA and ours test for the risk of or the actual presence of infection. And there is an importance there. Simply because it shows that you have high levels does not mean there's infection. But it does mean there's risk, and if there's a risk, you have to make sure they have no bleeding and that they're monitored on a regular basis. Oral DNA is going to test saliva more than it's going to test subgingival biofilms, and as such may not represent clinically what's happening under the gums. PerioProtect is a beautiful way of delivering antimicrobial solutions to the sulcus. But if we're talking about the infection being on the tongue, the back of the throat, the tonsillis, the teeth, the cheeks, then it's not going to address the reinfection issue, and we have to use the PerioProtect trays that are expensive, require multiple appointments, take 15 minutes 3 times a day for months, and most patients are unwilling to invest that type of time, and it doesn't treat the entire mouth. PerioWave with a laser and the use of a dye, you have to do multiple treatments again. The dye is expensive, and again, it does not treat the entire mouth. Periosciences and antioxidant rinses are great maintenance rinses, but they cannot penetrate resistant biofilms predictably the way an oral antibiotic rinse can, and as such, they are good if you like using them coming in after you've done an antibiotic rinse. Breath care with chlorine dioxide versus and chlorhexidine versus oral antibiotic rinses, testing and maintenance rinses. The difference is we get at the biofilm and kill it. They do a job of trying to control it, and as such, this is not predictable. This is virtually 100% predictable. So we're offering you options then to traditional cares that you might have been considering that are inexpensive, easy to integrate, and actually work more effectively. So in summary, you want to be visual and emotional, use analogies and stories, give them the mirror, show them the bleeding with the soft pick. Probing and scaling does not show an accurate bleeding index. If you see obvious inflammation, show the bleeding at the beginning of the appointment before you scale. Discuss what's happening on x-rays. Make it personal. Make it matter to them. Plant seeds discussing the oral systemic link and specific health issues. Express, I am concerned. I'm worried about this. This may be a problem. Ask if they're concerned. Tell them you have a system. And I tell patients I have a formula. And if they'll follow this formula the way I'm suggesting, I can almost guarantee the bleeding will stop. And the reason it doesn't is they're not effective in the way we teach them to brush, or the way we teach them to use soft picks or stimulants, or they did not use the rinses. But if you disturb and disrupt the biofilm on a regular basis, you are going to get them healthy. Ask them if they're interested with that. So we're leading edge and proactive. We offer the latest in clinical treatments. You truly will develop different relationships with your patients, enhancing their care. You are going to address the cause of the oral systemic link. Clinicians are going to be empowered to be able to take care of things in a predictable way. We can have a dream and vision of no bleeding or breath odor concerns. And the focus of the hygiene appointment is on health, not on the commodity services we provide. Not you need 4 appointments for cleaning and irrigation and that. It's about I want to stop the bleeding and how can I do it. You will get increased revenue, and you'll see a differentiation in your practice. So how do you earn money from OraVital? You're basically going to you're going to do an initial hygiene visit, but you may add the microbiological sampling. You're going to do the objective tests and scale. You'll have additional therapies that you may recommend along with the microbial rinses and the antibiotic rinses. You can do a reevaluation appointment. You're going to book more frequent hygiene. And if you add this type of thing up, the typical patient is going to spend about $434 on treatment. If you're treating 6 patients a month, that's what it is per month. That it is what for a year. And if you're treating 12 patients, those are the additional income that you generate. OroVital for breath care, $950 for 3 appointments, 2.5 hours with the hygienist. If you see existing patients, the fees could be less. New patients, you're going to have additional fees for x-rays and other services that you provide. They're going to add value to the practice. Each patient has a dollar value. They'll return for yearly exams and breath care of about $200 per year. They bribe proprietary rinses from you and keep coming back. It allows you to advertise new marketing opportunities and separate your practice from the competition, and no one else is doing this type of care. And so when you take a look at the return, 12 patients a year, 1 a month, that's what you learn. 6 existing patients are probably going to accept care at a reduced fee. You have 12 patients that have been introduced to the practice. That's the ROI on breath care. So if you take a look at things for just 6 patients a month doing perio, and that's very low, that's per year with breath. That's for 12 patients with breath. Big return for you. At this point, Danny, wanted to have some questions and perhaps discuss the special offer. Should I do that now, or are you doing that for me?
Well, first of all, thanks a lot. That was tremendous, and I know you covered a lot of material, and you did it just in the time that we requested. And I have to say that I think your delivery can just be best described as a comprehensive oral systemic practice treatment plan. And I just want to reiterate that the necessary first step for the doctor and the team, I think, is to be able to honestly answer the question in the affirmative, what if it were me? What is the standard of care that I would accept? And once they can say yes to that question, I think the rest is simple. I also think that you are underestimating the value, because the real value of what you offer is the patient loyalty. And you touched on it briefly, but people are going to talk about it. They're going to stay with you because you're, as you said, truly differentiating yourself, because sad reality that nobody is really practicing at this level right now. And I did want to thank and acknowledge you for the offers that you've made. And rather than, because we don't have a lot of time left, and we had a lot of questions. This is one of the most engaged audience we've seen in a long time.
Thank you.
Well, thank you. We will be sending this as our regular follow-up for details on the offers that you've generously made to our attendees. And let's get to the questions. Now, some of these are similar. I tried to sort them while I was getting them so we wouldn't repeat. And some of them are asking questions that, to some extent at least, you've already gone over, but I think you went over a lot. So, I think there's no problem going over some of these. Let's just dive in. The first one, in I hope some order of priority, is can you review again why a rinse and spit method of antibiotic delivery is more effective than an oral antibiotic?
It has to do with the dose you can deliver to the site of infection and the fact that you can deliver it 3 times a day for 2 weeks in the proper antibiotic and at enough concentration to penetrate biofilms. Biofilms are very resistant and to penetration of any chemicals. They're an organism that respond. But if you overwhelm them very quickly, they do not have a chance to respond and to even go into the spore state. So you're able to effectively penetrate the biofilm and kill them. And if you're combining that with a disruption technique that you're teaching the patient that they've never been using before, the biofilm is constantly broken up. And as it's broken up, the rinses can penetrate it even more. So it gets more effective as they go along in therapy because there's less of the resistant biofilm available, and the stuff that is available becomes more and more vulnerable.
I guess in military terms, you might term that a shock and awe strategy.
That's truly what's happening. I like that.
Number 2, you say that breath odor is virtually always related to an oral cause. Is this true? I've seen patients with a healthy mouth and no infection with breath odor. How is that? How can that be?
Anne treated over 5,000 patients for 15 years, and her study that she did was to try and determine why in healthy mouths was the breath odor. And what she found is that it's not the amount of bacteria, but it's the body's response. So sometimes patients will have a very heavy biofilm subgingivally on the tongue, around the gums, but your body doesn't respond with an infection. So when you look at it, you don't think that there's an infection. But if you analyze the biofilm, you'll see that it's heavily infected. And it's the level of the bacteria in the biofilm that counts and the amount that you have. So healthy mouths can look as if they would never have a breath odor problem, but they can have quite a problem. And I mentioned that I treat young children at times, and these kids don't have much biofilm that's visible, but they still have terrible breath odor issues. It's a different experience to help these people.
It is, and people often don't want to, they don't want the messenger to be shot. We don't like to be the bearer of bad news, and so often people with bad breath will ignore it. But as health professionals, it's really incumbent upon you to do it, because to address it and just do it properly. You shared a story with me before we went on the air, I think, about a woman whose mother had sort of, why don't you tell that story just briefly?
We had a gal in as a new patient last night, and I get about 4 new patients a month doing breath care, so it can be quite lucrative. And just so you know, earned $500,000 a year just doing breath care. This is a very significant thing for practices to consider. This particular gal, when she was 4 years old, she remembers her mother talking to her friends and saying, "I don't know what to do about my daughter's breath. I'm scared that people won't like her." And she was 22 when she came to see me. And this gal was scared to look at me. She's looking at the floor. She said, what my mom said has stayed with me my whole life. And it was a great neurosis for her. And when we were able to do objective tests and show she has the odors, she had a fair amount of bleeding in her mouth. She could smell where the odors were coming from when we flossed between the teeth and showed it to her. And then she had read about on our website. I said, "How did you find me?" She said, "You're the only one offering this type of therapy. I wanted to come and see you, and you had really good reviews." And as you start doing these therapies, you're going to get good reviews, and you get a better presence on Google because of it. So it's a joy to take care of this gal, but she was really affected her whole life by breath odor, and to be able to help her feels good professionally, because we're a healing profession, and you have to be sensitive to them. You can't minimize these concerns, but we didn't learn about it in school. We still learn about it from Listerine and from the breath commercials.
And I think and what was the time it took until she got results? It was like amazingly quick.
Well, in 4 days, they'll see significant changes because of the disruption in the biofilm. By the time a week comes, breath odors are usually under control, but the therapy is continued for 2 weeks with the antibiotic nonetheless to make sure that it's at a level where it won't be a concern. So it's very quick.
Okay. And this is, I think, a few questions similar to this. How am I going to tell my patients to stop brushing their teeth and not to floss when that's what everyone else is saying? And I added parenthetically, in fact, probably what they've been saying to them.
I just asked patients, if there was a way I could show you to clean between your teeth that didn't involve flossing, how would you feel about that? There isn't a person that doesn't hold their hand up. Danny, this is going to seem like a really interesting statement, and some of my team members are on the line. But when I have flossers that come in that are bleeding, I actually ask them to stop flossing.
Mm-hmm.
And I teach
flossing. The choir.
Yeah, I teach flossing for 2 occasions. If you can't get picks between your teeth or interproximal aids of some sort that you recommend, or if you have implants. If you have those, I will teach it. But you better teach them to use thick floss, to double or triple the thickness of the floss up, and teach them how to floss effectively in a C shape, perhaps by nodding their head or moving their jaw up and down so they can adapt the floss properly. And when you start getting to that level of care for patients, they understand you care and they pay attention.
Okay. This one I've got to ask. It's interesting. Well, I don't know that you discussed it. Will the antibiotic rinse cause resistance? Will its effect last?
The effects last for several years because of the way that you change the profile in the patient's mouths. Resistance is a term that we use in terms of chronic exposure to an antibiotic that breeds resistant organisms. Your shock and awe is the best thing that I can suggest. We don't give them a chance to get resistant with the concentration that's used. They don't have a chance to respond to it. The other thing is that metronidazole is unique in that it targets the DNA. It doesn't target the surface of the cell, so they don't generate techniques to avoid the antibiotic from getting into the cell. And when it does, it kills the DNA. When it does that, the cell dies. So they don't develop resistance to it. And if you give too low a dose or give it too frequently, you can develop spores, and they'll go into resistant state. That's what's seen with Lyme disease. But for the breath, odor, and gum care we're talking about, it isn't a concern. On top of that, which is more important, the concept of developing resistance or the patient who's at risk for Alzheimer's and heart disease and diabetes and preterm delivery and low birth weight or dying early? I look at those sorts of things, and if I have an infection somewhere, I know there might be some resistance that could occur, but I want to get rid of the infection first.
For sure. I'm going to read the last questions. I'm going to save time for you to answer one more, but I want those who were kind enough to submit the questions to know that we've got them and that you will respond to them. I'm sure many people are probably thinking of these anyway. First, I'm concerned that discussing the oral systemic wounds will upset my patients. How do you deal with this issue? Next question is, how does oral vitals microbiological report compare to oral DNAs? You could probably elaborate on that, although you did mention that. How do I introduce this concept when it is so different from what I've been saying to my patients? That's kind of related to earlier questions. What is the hardest part about implementing this process in an office? You know what, Jim? I'll let you answer whichever one of these you want. Let me just ask you the rest of them, and then you can choose.
I'll talk about implementation, because that's key. In other words, what we learn is nice, but what we do is what counts. And if you can't implement things and make a difference with what you learn, then you didn't learn anything. It's of no use to you. So to implement, you have to believe that this is what you want to do for every single patient. You have to have a leader, and realistically, that has to be the dentist. And they have to set a standard that this is what we're going to aim for. But please do not try and do every patient you see tomorrow with these techniques. Pick what I call the low-hanging fruit. Pick the ones you know that you've been trying to reach, that you have reasonable relationship. Pick those that are between 22 and 29 and talk about gum disease and how it's a kissing disease. Pick those that are 50 plus who are reached the stage in the life where they want to get healthy and make changes, and say, you know, there might be a different way we could bring the bleeding under control, and I'm concerned because we know these bugs are getting in the mouth. They don't stay in the mouth. They travel through the body. You've got heart disease and gut bleeding. Can I talk to you about some new things we've learned? And make sure that you follow a system, and I've given a system, which is periodontal charting, record the number of bleeding points, do a papillary bleeding score, discuss with the patient, do antibiotic testing, testing with for the bacteria, and then finally recommending rinses. Follow that formula. If you follow it, you'll always get good results.
Fantastic. And that's going to have to do it for us, but as I said, we promise to get you the answers to the other questions. At this point, I just want to thank you again very sincerely for the terrific presentation, as well as for the generous offers, which we didn't spend time on because our attendees will see that in a subsequent email. In a few days, you'll receive an email as well with instructions on how to receive your CE credit. And I want to invite all of you now to mark your calendars for our next webcast, which will be on Thursday, January 29th at 6 p.m. Central Time, when Dr. Charles Blair will present Stay Out of Jail, Insurance Coding and Administration Tips for the Oral Systemic Practice. Until then, this is Danny Bobrow thanking you for your continued commitment to practice perfection. And again, thank you, Jim, for a wonderful delivery.